Hi, my name is Connie Koklandis and you're watching the video on the management of essential infantile esotropia. Now, when we're managing a patient who's been diagnosed with this condition, there are two aims. One is to improve visual acuity if amblyopia is present, and second is to manage the strabismus itself. Remember, this is a large angle deviation. It's uncosmetically acceptable, so we want to operate and improve the cosmesis of the deviation, and also, where possible, give the patient VSV. Okay, we first have to consider the optical correction of patients with an infantile esotropia, because you will find that when they present as infants, there will be hypermetropia present. Now, as long as it's within the normal range of hypermetropia expected for that age, we would leave this uncorrected. And we do so because we want to allow for metropisation to occur. We also know that infantile esotropia is not an accommodative condition. Therefore, we know that if the child has infantile esotropia, that giving them their hypermetropic correction is not going to reduce the size of the deviation. However, where you find significantly high hypermetropia, the suggestion is that the patient could have an early onset accommodative strabismus, in which case you would consider giving the hypermetropic correction, because it may be that they have a partially accommodative ET, for example, that's presented early or has had an onset within the first 6 months of life. Moving on to occlusion, if the patient has amblyopia, then you need to occlude the patient and you need to ensure that you treat the amblyopia before surgery. Now, given that you're managing an infant, it is difficult to quantify visual acuity in some instances. The tests we have at our disposal is the teller acuity cards and the Cardiff acuity cards. But where a patient may not cooperate with those tests, you will utilise fixation as your guide. So when you assess the patient, what you want to see is, do they have a fixation preference? If they have an alternating esotropia, that indicates that vision is equal and there is no amblyopia. If they, for example, have a right fixation preference, so they have a left esotropia, then that suggests that there may be amblyopia of the left eye. So what you now want to have a look at is, does the eye take up fixation? Does it hold fixation? If the eye doesn't take up fixation, well, there's dense amblyopia there. If it takes up fixation but doesn't hold fixation, then it's likely that there is some level of amblyopia there, but it may not necessarily be severe. And then lastly, if the patient takes up fixation and holds fixation for a little period of time, then the amblyopia is likely to be mild. So you'll use that fixation as a guide. Remember also that it's been suggested that cross-fixation can protect a patient from developing amblyopia, but it's not necessarily a guarantee to prevent amblyopia. So don't let your amblyopia treatment be solely guided by whether there's cross-fixation. It's the cover test and the fixation of the patient in primary position that guides you as to whether you want to treat this patient for amblyopia. Now, in terms of the hours you prescribe, this will be dependent on the waking hours of the patient. So you're now dealing with infants. They're not awake for as many hours as the 4 or 5-year-old that you're patching. So you need to consider their waking hours. And in infants, you could be doing as little as half an hour of patching if you're concerned about occlusion amblyopia. The other point I've made there is to ensure you monitor visual acuity and potential amblyopia post-operatively. Now, we'll see in a moment that it's very unlikely, or there is a poor prognosis for patients achieving bifoveal fixation post-operatively, which means that there will be a residual deviation post-operatively. Could be consecutive if there's an overcorrection, but the aim will be to stay on the ESO side. As long as you have a manifest strabismus present, there is the risk of amblyopia. So whilst the patient may look good post-operatively and cosmetically there's been a significant improvement, or the strabismus is not noticeable by parents or family and friends, there is the real risk that amblyopia will develop post-operatively because even if the strabismus is not noticeable, it is highly likely that that patient has a small angle strabismus. Moving on to surgery, we have three options here. We can either perform unilateral surgery, so medial rectus recession, lateral rectus resection, bilateral surgery, so surgery on the two medial recti, or we can do through muscle surgery, where we do the two medial recti and a lateral rectus as well. This is for patients, or the through muscle surgery is for patients who have a very large angle strabismus, say a 65 diopter ET, where through muscle surgery might be warranted. Otherwise, it's generally considered to be a basic deviation, no difference near and far, and therefore you can do unilateral surgery. Many surgeons, however, prefer to do bimedial rectus recessions in patients with infantile esotropia. In terms of the aim of surgery, what we're aiming for is that the patient achieves a small angle strabismus within 10 diopters and will have BSV. What this means is we're aiming for the patient to post-operatively have a microtropia. Now, we'll aim for full correction, but the reality is that the patient has a very poor prognosis for BSV, or bifoveal BSV, I should say. These patients generally, at best, will have a microtropia with BSV, and at worst, they'll have a residual esotropia suppression and no BSV. Now, how do we go about achieving a microtropia? This comes down to timing of surgery. It is suggested that you have to operate on these children under the age of 2 whilst binocular functions are developing. There is debate as to whether waiting for after 2 years of age you can achieve BSV. And there is some debate about whether you should even go in earlier at the age of 3 or 4 months of age. However, the consensus is that if you operate under 2 years of age, you should be able to achieve a good outcome where the patient has a small angle esotropia with BSV. Okay, that brings us to the conclusion of this video. Thank you for watching.